Hello and welcome to our presentation. We are Team 1. Our focus area is on hospitals. Our project is on hospital compliance, specifically talking about patient observation status. The team is made up of Steve Albert, Karen Marie Buckley, Sylvie Hengen, Nick Odell, and Maren Thomas. The areas we will cover within this presentation, we will provide a background on patient observation status and a brief history. We will look at hospital compliance pre-discharge when the patient is still physically in the hospital, Medicare compliance post-discharge after the patient has left, the impact of compliance on patients and families, and its impact also on organizational morale. And we will finally close with best practices, looking at other organizations and how they handle observation status. So specific legislation that was passed, the Notice of Observation Treatment and Implication for Care Eligibility Act, or the Notice Act, was passed in 2015. It requires hospitals to provide specific notice to patients about their observation status. The Medicare Outpatient Observation Notice, or otherwise known as MOON, was developed to inform Medicare beneficiaries when they are in outpatient receiving outpatient services and are not an inpatient of the hospital. Observation status is a billing and coding category used for a patient who comes to a hospital who is too sick to go home, but not sick enough to be admitted as an inpatient. It's important to make the distinction that in order for a Medicare beneficiary to be eligible for skilled nursing care after being in the hospital, the patient must have been in the hospital for at least 3 days as an inpatient. Observation status does not qualify for skilled nursing care to be covered under Medicare. The Centers for Medicare and Medicaid Services, otherwise known as CMS, have advised hospitals that they must start using the MOON form by March 8, 2017. The form must be delivered to original Medicare and Medicare Advantage patients who are in observation status for more than 24 hours. Hospitals must provide the MOON no later than 36 hours after observation begins. In 2014, the Connecticut General Assembly passed Public Act 14-180, an act of concerning notice of a patient's observation status. This is Connecticut's own version of the MOON Act, and it has similar provisions to the MOON requirements. Notification requirements are still in place, but the more pressing health policy question remains, and congressional members continue to work in a bipartisan way to try to have Medicare count time in observation towards the 3-day requirement for skilled nursing care. In this next section of the presentation, we will talk about hospital compliance, specifically pre-discharge when the patient is still here. So when we talk about the emergency department, specifically its characteristics, it's a very unpredictable environment. It needs to be fast-paced. It requires quick decision-making. Other than patients that are coming in for a scheduled procedure in the OR, all patients come through the emergency department. Before patient observation status, the decision matrix was very simple. It was binary. You either admitted the patient or you discharged them. Having just a binary decision matrix causes two major risks. The first one is around patient safety, and this is when a patient gets discharged when they shouldn't have been. And this can also lead to elevated levels of patient readmission after they are discharged. The second major risk is around wasted resources. When a patient is admitted when they shouldn't have been, they were here for 3 days. After the fact that the patient record is reviewed, it's determined that the diagnosis did not warrant an admission and the Medicare denies the claim. So in this sense, in essence, that bed was a wasted resource and is no longer not paid for by Medicare. In the scope of compliance, here are the 7 elements that make up an effective compliance program. The 3 elements that we will focus on the most will be around written policies and procedures, effective training and education, and the use of corrective action plans. So when a patient comes into the hospital, there's a lot of decisions that have to be made. The first decision that's made is when the patient first enters the ED. There's an initial determination: is the patient critical? If it's a yes, then they are determined to have an immediate need, and they have to go to the OR, or they have to go to critical care. They need advanced services, etc. If they're determined not to be a critical need, where they're determining that they're going to die like right now, they're going to go under the care of a provider, and they're going to go through an exam. They're going to have test orders. They're going to have results, and they're also going to rely on the provider's intuition, which I highlighted specifically because this is a major determining factor in what the provider is going to do. So when the provider then gets the exam results, determines a diagnosis, they're going to come up with a medical disposition. So instead of having a binary decision where it's admit, discharge, now we're at the point where it's an admit, discharge, or now observation. And that's obviously what we will focus on now. To look at patient observation status in more detail, we did a case study around a Connecticut hospital. Some background on this hospital: they currently have an annual volume of 120,000 patients a year. During its high volume season, they experience high wait times. There's overcrowded. Patients are in the hallways. Several people are in the waiting room at any one time. They experience low patient throughput. And it's also associated with low patient satisfaction scores. This is a hospital that has just started integrating and using the observation unit a little bit more. The specific barriers around this observation status is the communication that they're finding within the department, so within the ED. Who knows about it? What does it mean? The communication with other departments and the communication with patients. And we will take an in-depth look at all 3 of these. To address the first barrier around observation status, specifically the communication within the department, this specific ED created an observation council, and this observation council is tasked to track and own 3 specific metrics. The first metric is daily observation patient status, which has a goal of having more than 10 patients per day that are in observation status. So the goal is 10, and currently the output is less than 4 a day. So this goal is currently not being met. For inpatient, the second metric is around inpatient conversion rate. The goal is over 20%. Currently it's at 30%, so yes, this goal is being met. Length of stay in observation status, the goal is to be in that status for less than 18 hours. Currently it's less than 17 hours, so this goal is being met. So the common barriers that are related to the daily census: the ED providers are just unknown of the parameters around observation protocol. They are just unaware of exactly what it is, what happens. Am I just passing my patient on to another provider? If the observation status is used, is this a delay that's just is it result driven, or is it just delaying the decision that provider is going to make or already made? Another barrier, the final barrier is specifically a high turnover of residents with lack of training on observation status, so the communication doesn't get out, and this leads to a lot of patients that should have gone into observation status but didn't necessarily make it. The second barrier around communication with other departments, it's important to note that within this particular hospital that observation patients can be located anywhere within the hospital. So currently within the emergency department, there are emergency department observation patients. There are other observation patients that are physically located in the emergency department. So this creates a huge communication challenge with other departments. So you have other providers from other service lines, medicine units, cardiology units, neurology units. You have nursing, you have support staff. So it creates a huge communication gap as far as what the status of these patients is, who owns what's the turnover, what's the communication handoff. So that's around the communication with other departments. So the communication with patients. So earlier we talked about the Notice Act. So per the Notice Act, the provider informs the patient of the observation status. Two challenges with this, specifically in this particular ED. When this notification goes to the patients, they have questions about billing in regards to observation status, and the providers can't provide this information. So they are directed to, the patients are directed to contact their uh, insurance provider to get that information, and it becomes a huge patient dissatisfier at the time. And the other barrier, the other challenge in this is that the department currently does not have an identified area specifically for observation patients. So a patient could physically be somewhere where other patients are that are still technically part of the ED, part of an ED status, but have been deemed to be observation patients, but they're still physically in the ED. And it becomes just very confusing for patients, and again, a huge dissatisfier for them. So after understanding these specific communication barriers, this particular hospital is going to use the Plan, Do, Check, Act PDCA model to develop a corrective action plan to address these specific barriers. The first element of the corrective action plan is to develop and deliver a training module for all hospital staff, and this will be rolled out including any resident onboarding training program. This particular training will address observation status, its particular benefits for patients, the staff, and the organization. Another recent happening for this particular ED, they recently proposed and the hospital administration approved the construction of a brand new ED observation unit. And this is significant because this will be a designated area which will have specific individual rooms, its own staff. It'll have proper equipment in the event that if a patient is in there in observation status and needs to be upgraded, they have the proper equipment in there where if an inpatient room is not available at the time, this particular observation unit can provide the necessary medical treatment for that particular patient at the time. So the ED has become a primary point of care for many Americans. In 2009, there were more than 136 million ED visits at 4,967 hospitals. Of that total, 13.4 resulted in inpatient admission. Observation visit volume has been increasing. In 2012, there were 1.5 million observation stays for Medicare beneficiaries, resulting in a 300% increase over previous years. Along with this growing demand, rising costs and declining payments have threatened the financial viability of many hospitals, resulting in a trend of both emergency department and hospital closure over the past decade, and creating a mismatch of supply and demand for acute care services. So what does this mean for hospitals? So to that end, hospitals have been looking for alternative models for efficiently treating observation patients at lower costs. A particularly promising alternative model is the dedicated use of hospital observation units for short-term stays. Delivering care in an observation unit is an alternative to admitting patients who cannot be safely discharged to their homes following an ED visit. Studies have shown that this model provides equal or better quality at a lower cost than inpatient care for specific conditions. Although these units may be located within the hospital, these patients are coded as outpatient care. These units have standardized care and are used to avert costlier hospital admissions. When researchers simulated the potential cost savings, they found that using observation units could save approximately $4.6 million per hospital and up to $3.1 billion nationally. Hospitals have been slow to migrate to this new model because of its high upfront cost and space issues. Capacity-filled hospitals would need to add on or reuse existing space to create dedicated observation units. Another area hospitals are researching is changing the unit billing models. Currently, many hospitals utilize an emergency department observation unit, otherwise known as an EDOU, which utilizes protocol care to offer shorter lengths of stay, lower costs, and higher patient satisfaction. However, existing barriers that prevent a two-service model of separate professional billing for emergency and observation services limit EDOU's growth. Typically, EDOUs use the one-service model where a single billing code are utilized for emergency and observation statuses. Current procedural terminology, otherwise known as CPT, policies predate modern observation care and prohibit professional billing for emergency services and observation services on the same date of service by physicians from the same specialty in the same group. In other words, if a patient transitions from the ED to observation with physicians from the same specialty on the same day, then the hospital is required to bill it as the same service. However, if a patient starts in the emergency room but another non-emergency physician provides the observation care, then both the emergency room service and the non-emergency service can be billed separately. This would be the example of a two-service model. Researchers used simulation models to compare the cash flow utilizing the one-service model versus the two-service model. When the one-service model is simulated, figure on the left, there is no break-even point that exists, and in fact the net loss increases with billable encounters requiring a hospital subsidy. Under the two-service simulation, which is the figure on the right, the break-even point was met after a minimum daily observation unit billable after encounters after over 20 patients. Hospitals should consider the feasibility of updating their business model to allow billing of observation care under the two-service model and see if it can help offset their costs. When considering patient observations versus admissions, hospitals need to consider these options as well as others to keep their costs down and improve the quality of care. Many hospitals were designed and built prior to the modern observation care practice had begun. They will need to change their business practices to fit this new need in their healthcare. This includes the potential need for changes and upgrades to the physical plant and also an evolution of business practices. To stay viable, the modern hospital will need to keep nimble and fluid and adjust as the needs of healthcare continues to evolve. Payments for observation stay are paid through Medicare Part B under the Outpatient Prospective Payment System, otherwise known as OPPS. Therefore, patients have higher deductibles to pay. Beneficiaries in observation stay sometimes paid more than the deductible charged to the beneficiaries in inpatient stays. Inpatient is covered under Medicare Part A, and it will cover the inpatient stay fully. This is burdensome to the patients who have higher deductibles because their observational status is seen as an outpatient service and disqualifies them from being transitioned into an outpatient skilled nursing facility. So as mentioned earlier, the Notice Act requires hospitals to inform patients hospitalized under observation for 24 hours or more that they are under observation and of all of the financial implications. Hospitals must maintain a patient's signature on the Moon form within 36 hours of the start of an applicable observation stay. Informed patients can ask physicians to change their status, but physicians must comply with Medicare rules in assigning inpatient or outpatient status. If they do not follow these rules, it will be Medicare fraud, so most likely the patient's status will not be changed. The organization has a moral obligation to the patients to simplify the process for Medicare beneficiaries and have a capped out-of-pocket deductible that is maxed out regardless of status. Payment policy in place that is simple and easy to understand, that can easily break down what the patients will be paying for the observation status, is a viable option for hospitals to use. When we talk about best practice, we have to first observe the problem. So the current problem, hospitals nationwide are still facing significant room shortages due to unnecessary inpatient admitting through the emergency departments, causing a high patient acuity in emergency departments, causing a ripple effect leading to longer wait times, frequent diversions of patients to other hospitals, and a shortage of beds. A sizable and a practice in regards to this is a sizable amount of inpatient admissions can be prevented with a dedicated clinical observation unit. And these units buy the much needed time that EDs fundamentally are lacking to observe the patient to see if their symptoms are worsening or getting better. The clinical observation unit is a winning model as far as stakeholders are concerned. Essentially, many see the unit as a fine blend of clinical care, fiscal responsibility, and patient accountability. Amongst the benefits are reduced admissions, reduced resource utilization, and improved case mix multiplier. Other common best practices, we talk about infection control, which hospitals with clinical observation units tend to have lower infection rates due to decreased patient movement and less provider contact exposure. Prompt and standardized care. Most clinical observation units practice evidence-based medicine and have a standardized approach to care. And the third one is patient safety. Patients in the clinical observation units also often have less patient errors because of the bulk of patient treatment is given in one geographic area rather than being moved around and as far as communication with other parts of the hospital. From a best practice standpoint, clinical observation units work. However, they are not without some complex issues. Logistics and reimbursement seem to be the most pressing issues. Overall, the concerns include compliance concerns, who owns the patient, how much of a role does the consulting physician have, who oversees the follow-up plans, and specifically around reimbursement, the inpatient or outpatient, the flow of the patient, the path of the patient through the ED, through the hospital, and the overall experience of the patient. These are all variables that the hospital must consider.